Good afternoon, everybody. Thank you very much for the invitation to speak in your Congress. It is a real pleasure. My only regret is that I cannot join you physically, and I have to do this from Europe. What we're going to talk about today is genetics, but not genetics for a research institute, for a high-powered genetic university. We're going to talk about genetics for general practitioners. And what I want to show to you is that genetics is a tool for you here today in your general practice. And I want to give you some ideas about how to think genetics. How should I use genetics in my normal day-to-day medical work? And in the background to this is really this citation from the former chief medical officer of the United Kingdom, who many years ago, 7 years ago already, said, "Genomics is not tomorrow, it's here today. Genomic services should be available to more patients whilst being a cost-effective service." And this, I think, is the secret for you as the frontline practitioners. You are the first contact of patients with the health service, and you need the skill and the sensitivity and the knowledge to use genetics to improve diagnostics for your patients. Genetics can be used really in 3 different ways, and we'll go through some examples of real case reports from my laboratory in Switzerland about how they can be used. Obviously, genetic tests can discover hereditary genetic predispositions. For example, genes predisposing to breast cancer or to ovarian cancer. I think the most interesting of all, perhaps for you as general practitioners, is the middle section on this slide, where you're in front of a patient who hasn't had a diagnosis for many years, who is giving you problems diagnosing him, where you're not happy about the association of which signs are together. It doesn't seem right to you. And in this situation, genetics can be very powerful in making the correct diagnosis in a previously undiagnosed or misdiagnosed condition. Remember that most patients, about half of them, wait for at least a year for a diagnosis of their genetic disorder, and 1 in 8 patients have to wait more than 10 years to know what their condition is. And then, of course, finally, we can use these genetic tests for very common disorders, and we will select some of those. But we can also use them for very rare disorders. And even though you will see these only occasionally in your practice, you still need to be ready. I think I have a rare genetic disease in front of me. I have to know how to ask for the test. So let's take a look at our first case. This was a case that came out of our SYNLAB network. I was contacted by a colleague and friend who was chief medical officer in Romania. And she said to me, "Mike, I'm following a gentleman of 51 years old. He's of Irish origin, lives here in Romania, and he's been consulting his GP with joint pain, and the GP doesn't find anything very clear to explain his joint pain. We did routine labs on him, and we found he had hyperferritinemia, but that's not so surprising when you have an inflammatory condition. And the GP said, come back later if you still have problems. I don't see anything particularly severe here." He came back again later with swelling, with worsening pain in the fingers, very, very much in the fingers, to some extent in the hands. And my colleague asked for a photo of his hands. Here you see a typical appearance, not exactly the same photo, and there was clear skin pigmentation. Based on this, we decided not just to do basic bloods, but we did a transferrin saturation test. The transferrin saturation was actually so high, it was impossible to calculate it. And so this is where Sherlock Holmes, my favorite geneticist, comes into action. We have 3 keywords here. We have Irish, we have joint pain, and we have skin pigmentation. Now, you may remember these from your medical school. These point us to what in Europe is sometimes called the Celtic curse. It's known that the Irish, they have wonderful luck, they are charming people, it's a great country to visit, they're very happy. They have the highest incidence of hereditary hemochromatosis in the entire world. About 1 in 8 people are carriers of hemochromatosis. About 1 in 250 people are homozygotes predisposed to developing this genetic disease. The typical symptoms are highly variable in hemochromatosis. In the classic advanced forms, you will find liver disease, skin bronzing, and cardiomyopathy. But usually the onset is much more subtle, with fatigue, with loss of libido, with abdominal pain, with diabetes. And you may well know that almost all cases, about 95% of cases of hemochromatosis in the world, are caused by the same mutation in the same gene, a gene called HFE, and a mutation called C282Y, which means that a cysteine in position 282 in the protein is converted to a tyrosine, abbreviated as Y. Throughout Europe, in most European populations outside Ireland, about 1 in 400 to 1 in 500 people carry this genotype, which puts them at risk of developing hemochromatosis. I had a look in Mexico. There was a nice study in Mexico City which showed that the prevalence of people with this at-risk genotype is about 1 in 5,000 to 1 in 10,000. So officially classified as a rare disease, but still quite a common rare disease. And importantly, it's entirely preventable if it's detected early. As I said, over 95% of patients carry the C282Y mutation in 2 copies, homozygous. Many laboratories also test 2 other variants, H63D and S65C, but in fact we no longer consider these as variants causing genetic disease, causing hemochromatosis. They may lead to a little bit of iron overload, but they will not cause clinical hereditary hemochromatosis. The 5% of patients who don't have this common genotype can have mutations in a number of different genes. Here you see a list of 7 or 8 of them. And these can only be detected by doing much more complicated tests through next generation sequencing. And so we have to decide, how do I use this test? How do I proceed? When should I think of hemochromatosis? And what is the effective and efficient diagnostic pathway? So let's go back to Sherlock Holmes. The first thing you look for when you're looking for a genetic disease, when you want to think genetic, is an unusual association. Primary liver cancer with arthritis, fatigue in an Irish person, arthralgia and diabetes. Quite common in genetic diseases that you have unusual signs, multiple signs, which make up part of the pathognomony of a disease, but you don't normally associate them. For hemochromatosis, there are quite strict workflows that have been defined now. You will find the reference in the presentation that we can share with you afterwards. And the best recommendations available at present are those of the European Association for the Study of Liver, published in 2023, where the workflow is quite clear. If you suspect hemochromatosis, or you identify an unexplained hyperferritinemia, over 300 in males, over 200 in females, you should then proceed to transferrin saturation testing. If your transferrin saturation is above 45%, then you have an indication to go ahead with the basic hemochromatosis genetic test, which has the strongest discriminating power, yes or no. And so you perform a PCR test on a cheek swab, on a blood sample, looking for the HFE C282Y mutation. If you find that your patient is homozygous, you've achieved your diagnosis. You've confirmed the diagnosis of hereditary hemochromatosis linked to HFE. You know how to treat your patient. And in most cases, the treatment is simple blood drawing, phlebotomy to reduce the iron concentration. You follow your patient's iron levels. You adjust the frequency of phlebotomy for what is convenient and effective for your patient. And it also opens up the possibility of preventing disease in other family members, because, of course, this is a genetic disease. If I, as a 60-year-old male, am diagnosed with hemochromatosis, my brother, who is a 63-year-old male, and my sister, who is 62 years old, are also potentially at risk. And so they need cascade testing, they need surveillance, and in this way we can prevent them ever getting clinical disease. Now, in most cases, we don't manage to confirm the disease just by doing the C282Y test, because there are other causes. So if this comes back negative, what should you do to proceed with your diagnosis? The first thing to do is to analyze the tissue iron stores. Traditionally, this was done by liver biopsy. Now this is generally done by imaging. And if you can show an increase in the tissue iron stores, you then have an indication that you should go on to do the more complex genetic test, only available in specialist laboratories and centers, to look for a rarer form of hereditary hemochromatosis linked to a gene other than HFE. So let's go back to our patient, our Irish gentleman. This is his report from my Romanian colleague. And indeed, expectedly, we found that he was homozygous for an HFE C282Y mutation. You see his genotype written in genetic language here, a very simple interpretation here, and basic guidelines of what we should do to this patient. Your genetic report should always tell you, and if it doesn't, please ask your laboratory to be clearer. It should answer your clinical question. You have asked us in the laboratory, does my patient have hemochromatosis? Yes, this result is compatible with the diagnosis in the presence of tissue iron overload. We add a disclaimer because most people in the world who are C282Y homozygotes will never actually develop clinical hemochromatosis. This is what we call incomplete penetrance. Probably only about 5 to 10% of people across the world will develop clinically important iron overload and develop symptoms because of this. And so I do not necessarily know if your patient has an iron overload in his tissues. That is your clinical decision. Once we have this genotype, whatever the situation of the patient, it's really important to regularly monitor your patient's iron parameters. In 2024, patients should not become seriously ill from hereditary hemochromatosis. The severe disease is entirely and cheaply preventable. Secondly, we have a genetic disease. We have other people in the family who are potentially at risk, and so genetic counseling is indicated. And we will remind you of this in the laboratory report. And thirdly, we'll mention why genetic counseling is indicated. Other family members are potentially at risk. We need to know the structure of the family, brothers, sisters, even children. And these people should have their iron parameters monitored. We would actually recommend doing it rapidly, because maybe somebody is already developing a clinical disease. And whether or not you detect abnormal iron parameters, we recommend predictive genetic testing. Maybe we'll say, my brother is genetically at risk. We need to monitor him. My sister does not carry the same mutations. We can reassure her she does not need monitoring for iron overload. So if we look in a bit more detail at the family, here is the family of the Irish patient we tested. He is here with the arrow, our index patient. He is both affected and has a positive genotype. He had a sister who was older than him, and so she is potentially at risk and needs testing. Both parents should be offered testing, at the very least, for iron parameters. Each of them will certainly be a carrier of a mutation. It's possible one of them will have a second mutation from somewhere else in the family, and so they could also be at risk. And finally, his children. Testing for adult children is recommended. Iron monitoring, even from the age of young adults, can be valuable. Even from between 20 and 25, you can start seeing perturbation of the iron levels. Testing for minors, children under the age of adulthood, is not recommended. There is no need, there is no clinical advantage. Equally, we can offer genetic testing to the adult child. Again, if he's negative for the mutations, he is not at risk. He does not need regular iron monitoring. If he is positive for the two mutations, has the same genotype as his father, then he would need monitoring. And equally, he would need advice, for example, to avoid iron supplements, which could significantly increase his iron overload. It's worth mentioning as well, when we talk about genetic diseases, quite often people think, oh yes, prenatal diagnosis. Prenatal diagnosis is not considered appropriate in an entirely preventable disease like hereditary hemochromatosis. So that's our first very simple case. We can ask ourselves, why am I getting involved in genetic testing? Why am I doing it? Clearly, in this case, your first desire was to determine or to exclude the diagnosis of a genetic disorder, hereditary hemochromatosis. But we see it also has other utilities. It's allowed us, by making the diagnosis, determine both the best treatment and the appropriate surveillance for patients. And it's also allowed us to test other family members through cascade testing and to identify people at risk of developing disease and preventing them from developing disease. So now let's go to our second situation. This actually happened with a member of a family of a colleague of mine. He was a European male, highly educated, worked in a university hospital, 39-year-old Swiss male. Since childhood, he'd had migraines and always been troubled with them. For many months, he'd been suffering from chronic abdominal pain, and he'd had a number of specialized gastroenterology consultations, had had a gastroscopy and a colonoscopy without any remarkable results. Here you see his immediate family. His mother had a similar situation for many, many years. She had suffered from fatigue, from abdominal pain, like our index case. She suffered from regular diarrhea and vomiting. She'd had years of specialist consultations, from her GP going through to gastroenterologists. She had had every possible examination. And in the end, she was, in her own words, she said, "I'm resigned to always being ill. And in particular, it spoils family celebrations. I don't want to go at Christmas. I don't want to go to birthday parties because I'm always sick." And then to our index case's daughter, she was 7 years old at the time we worked up the family. She had also started migraines quite young, at the age of 5, and she was starting to develop abdominal symptoms with a swollen stomach and uncomfortable gas. You may already be thinking of a possible diagnosis here. 3 generations affected with a similar abdominal gastro-systemic problem. We immediately tested just one nucleotide, one of the 3 billion bases of the human genome, because we were absolutely convinced we knew what this family was suffering from. They are suffering from primary, there's a spelling mistake, primary lactose intolerance. As soon as we made the diagnosis in our index case, we showed that he had the genotype predisposing him to lactose intolerance. He switched entirely to consuming lactose-free products, stopped drinking milk, only drank lactose-depleted products, avoided foods with added lactose, and the symptoms disappeared within less than a month. So what is lactose intolerance? There are three different causes. The first cause, to be honest, I have never seen in 36 years of medical genetics. It's a pure genetic disease. It affects very young babies. It's a congenital disorder. Babies have a congenital absence of the lactase enzyme, and so cannot digest the lactose in their mother's milk. Extremely rare disease, but there are cases known. Much the most common form is primary adult hypolactasia, which is due not to a genetic absence of the lactase enzyme, but to non-persistence of lactase. As you know, humans as babies, we rely on mother's milk to survive. It's our principal energy and nutrition source. But biologically, from about 5 to 10 years of age, we lose our dependency on our mother's milk. And as an energy-saving device, we have evolved to switch off the production of lactase. If we don't need it to survive, why use the energy to produce it? And so this is an entirely natural human state. We will see on the next slide how this looks. The third form of lactose intolerance, which can be a confounding factor, is secondary lactose intolerance, which is very common in any diseases, such as celiac diseases, such as gastrointestinal dysbiosis, such as infections, for example, including Giardia, where there's mucosal damage. The intestinal mucosa fails to produce lactase, but this has the same symptoms, but is reversible if you repair the mucosal damage. So how does the loss of lactase persistence look? First, I'll concentrate on the European graph. Here we have the proportion of population who are tolerant to lactose, who can drink a large glass of milk without any issues at all. And you see all of us between 1 and 5 years of age, we are almost all entirely tolerant. Don't confuse this with allergy to milk. That's a completely different story. Europeans, over the first about 10 years of age, slowly become intolerant, but the great majority of white Europeans, about 80%, stay tolerant to lactose, can drink milk into adult life. The opposite extreme are the majority of African communities, where very quickly the great majority of people cease to secrete lactase, become lactose intolerant, and by 9 or 10 years of age, the great majority of Black Africans are intolerant to dietary lactose. The Mexican population, you know better than I how complex its genetic mix is halfway between the African and the European population, perhaps not surprisingly. And there's a steady decline or steady increase of lactose intolerance over age from about 3 to 15 years of age. If you look across the world, you see, as we suspect from this graph, there is a huge ethnic variability with almost complete intolerance in Africa, almost complete tolerance in Europe, and the mix for the rest of the world. In Mexico, on average, about 3 out of 4 adults are intolerant to dietary lactose, but the severity can vary. How does this happen? This is actually one of the rather cool things in genetics. This is one of the best examples we have of evolution within the human species during the existence of Homo sapiens. I don't want to go into too much detail in the genetics, But here we see a representation of the lactase gene, the gene that produces the lactase enzyme. It has a promoter that tells it, make messenger RNA, make protein, make the enzyme. And like most promoters, there are regulatory regions which switch on or switch off the gene. And as I said, in human infants, the gene is switched on, we make lactase, because without that, we would not survive. What is remarkable, that about between 6,000 and 8,000 years ago, a number of mutations happened in this regulatory region, as they happen randomly throughout our genome over time. And if we concentrate on one particular mutation, this minus 13910C to T, one base in the entire human genome, was mutated, and the effect of this mutation was that the lactase gene could no longer be switched off. It blocked us from switching off the gene. And that meant that adults with this mutation carried on secreting lactase and could carry on drinking milk containing lactose or survive on other lactose containing diets. This was very important because this was close to the end of the Ice Age. It was at the beginning of domestication, when we were starting to domesticate sheep and goats, and it was associated with periods of severe famine, where the only way to survive was be able to profit from your goats and sheep, to drink their milk, to live off their fresh cheese. And so people who had this mutation better survived the famine. This is a true example of the survival of the fittest. What is amazing, that in similar period in history, other mutations have appeared very much in the same region, within a few bases in the human genome, with mutations appearing in Sudan, in Arabia, in Ethiopia, in South Africa, all of them having the same effect, that in some ethnic groups, the lactase enzyme persists into adulthood. And so you have lactose-tolerant adults. The presence of any one of these variants causes lactase persistence and excludes the diagnosis of primary lactose intolerance. As I said, in Mexico, about 75% of people are lactose intolerant. In Switzerland, it's much smaller. It's only about 10% of people. And this genetic test provides an outstanding test in Switzerland and also in Mexico for diagnosing primary lactose intolerance. If you suspect this in your patient is homozygous C, he is, or if he was a child, will be intolerant to lactose. If he has a T at this position, 1 or 2, he will not have primary lactose intolerance, and there you should consider alternative diagnosis of what may be a functional lactose intolerance. Maybe he is at the early stages of celiac disease, for example. Just one note, if you're looking at ethnicities, Black African or Arabic ethnicities, you should be using some of the more modern and more complex tests which detect these other mutations that I showed you that have appeared through history. So let's go back to our patient. We did the test on him. We showed him he has a CC genotype. He adapted his behavior and his symptoms disappeared completely. Of course, we then went on to test his mother and his daughter, both symptomatic. There are no problems doing a genetic test on a child if it's to explain their symptoms. As expected, the mother was also CC. This confirmed her primary lactose intolerance. The good news was that we could switch her to a lactose-free diet, and her symptoms disappeared again completely after decades of being sick. She did remain angry with her doctors all the years of medicalization, where nobody, including the gastroenterologists, had ever considered maybe you just have lactose intolerance, a completely normal human state. And his daughter, Young 7-year-old girl. Again, we identified primary lactose intolerance. And so her milk was replaced by lactose-free milk. Obviously, you must not entirely remove milk from the diet because it has other dietary benefits, notably calcium, but you have to bring down the lactose content. And so based on this, her symptoms disappeared, and now we have a happy lactose-free family. So once again, we've managed to confirm the diagnosis of a genetic disorder. As I told you, it's barely a genetic disorder, but we have a genetic explanation for the disease. And this allowed a very simple dietary modification to treat and cure these patients. And now we move on to the third case, a remarkable case, a rarer disease, but a group of these genetic disorders where the delay to diagnosis is often 10 years or more. So this is a story of a young Swiss woman who since childhood had had problems with urticaria, which was never explained, never responded to basic treatment. And in adolescence, she progressed to arthralgia and arthritis, which notably had acute episodes, handicapping episodes, which were triggered by cold. As you may imagine, this is a more severe problem in Switzerland than it would be for you in Mexico. From the age of about 25, she developed recurrent uveitis and conjunctivitis, and added to her diagnostic migration, she'd been followed by pediatricians, of course, by dermatologists. Now she went to an ophthalmologist. And finally, she arrived in a university department of rheumatology and described to them her own symptoms, but she also said, my sibling and my mother have similar signs. So at the age of 30, she had her rheumatology consultation. Clinically, they observed mild urticaria on one arm. The patient said, yes, I have it every day. It's never particularly severe. Last week, I did have a bad episode. I'm stressed at work. As you know, it was cold, and I had quite a painful and uncomfortable urticaria. Recently, I've had 2 episodes of arthralgia. Her knee was observed to be swollen. And taking non-steroidal anti-inflammatories rapidly resolved this inflammation. She'd learned to control it. The biological workup unexpectedly showed CRP was elevated. Hemoglobin was about 120 grams per liter. There was no proteinuria. So once again, we call on our friend Sherlock Holmes. And remember, this lady, as a child, started her diagnostic odyssey. She has been waiting 25 years to find out the cause of her disease. She has urticaria, she is cold sensitive, she develops arthralgia, she has an inflammatory syndrome. And this moves us into the field of the hereditary periodic fever syndromes. There are quite a lot of them, but 4 of them are particularly common. The first one, familial Mediterranean fever, is certainly the most common in Mexico. It's particularly common, in fact, in Mexican Jews, with very high incidence. So you see here 4 common diseases: familial Mediterranean fever, mevalonate kinase deficiency, TRAPS, and CAPS, cold-associated periodic syndrome. Each of them is caused by defects in a distinct gene that can be tested. In the case of CAPS, the gene is called NLRP3. Each of them has their own manner of hereditary transmission. You see the first 2 are recessive. Each parent has to be a carrier to pass on mutations. The second 2 are dominant. They go from generation to generation. The onset varies hugely from infancy, like in our patient, up even to adult onset in some cases. Each of them typically has crises of fever, inflammation, arthralgia, rash, and the duration of these episodes can be quite different and useful to distinguish between the different diseases. And each of them has their own complex pattern of symptomatology. And you see here I've highlighted urticarial skin rash and arthralgia. Curiously, our patient never reported fever, which is common in these situations. Other signs, conjunctivitis is common in this, and our patient, as you saw, has developed conjunctivitis, and cold-associated periodic syndrome, as you guess, a cold trigger is very common. These are not just unpleasant diseases, but they are life-threatening diseases, particularly because of renal amyloidosis, which develops in patients over life if the diseases are not controlled. And there is a significant risk of amyloidosis in CAPS if the patient is untreated. So we strongly suspected CAPS in this patient, who was an absolutely typical presentation. We actually perform a standard test of about 8 to 10 different genes involved in periodic syndromes, just to make sure that we're not missing the diagnosis completely. But as expected in this patient, we found a mutation in the NLRP3 gene, the typical gene of cold-associated periodic syndrome. This mutation is not well understood, but has been described, as we mentioned in the report. It has been described in a number of other patients with CAPS, in particular 2 subtypes. And it's also described in a professional database called InFevers as likely pathogenic. And so given the typical symptomatology, given the typical mutation, we noted that this result completely supports the diagnosis of CAPS in the patient. So what was the effect on our patient? For a start, the effect on my colleague, the rheumatologist, was marvelous. He said, when you make a diagnosis like this after 25 years, the patient thinks you are God. And so the patient was hugely grateful for this diagnosis. What is important with this diagnosis is that there is a targeted treatment. For the last few years, there's been a targeted anti-IL-1 beta monoclonal antibody, which has an absolutely remarkable effect on the symptomology. Instead of having daily treatment, anti-inflammatories, some of the less effective IL-1 pathway antibodies, a monthly injection with canakinumab can completely cut the symptomatology and has a huge importance in the long term for reducing the danger of amyloidosis. And so the patient will be put under canakinumab, and also, because we have a diagnosis, we will, of course, test the other family members, not just her mother and sibling who are symptomatic, but all the other family members who are asymptomatic, but who are potentially at risk. At the latest news, the patient had received her first dose of canakinumab. On the basis of 1 dose, she stayed almost asymptomatic for 2 months, with just 1 episode when there was a cold snap, a few days where the temperature dropped rapidly, and she had an episode of urticaria arthralgia. And so again, this effectiveness of canakinumab strongly supports the diagnosis that we've identified the cause of her 25-year medical history. And so once again, we tick several boxes. In this case, a new box. By doing the right genetic test, by putting the right signs together, we've managed to identify a rare inheritable disease in the patient and been able to identify the targeted treatment. And so on to our last case, a very common situation, patient with cardiac disease, a male, 52 years old, who had a sudden myocardial infarct. On questioning, it turned out he was part of quite a complex family. You see, his elder brother had died recently of a sudden myocardial infarct. Luckily, our patient didn't die. We also learned that his younger brother had a hypertrophic cardiomyopathy. Nobody had ever put together the rest of the family. the patient's parent had died of a sudden myocardial infarct at 72 years of age, and there are other less clear deaths in the family. A sudden MI at 86 years of age, a young death at 3 to 4 years, unexplained, a grandparent who died at 40 years of unexplained causes. And in addition, there are a number of children. The 3 affected males who are still living had a total of 7 children who are potentially at risk if we manage to identify a genetic predisposition. So hypertrophic cardiac myopathy is without doubt the most common genetic heart disease. It varies a little around the world, but globally the prevalence is about 1 in 200 people carry mutations predisposing to HCM. The clinical heterogeneity is its absolute hallmark. The patients can be entirely asymptomatic, they can have arrhythmia, they can have heart failure, or the disease, as in the case of the elder brother, can present as sudden death. So here we have to ask ourselves, what type of genetic test do we want to choose? We don't need to read this in detail. We'll just read down the left-hand side. If you're interested, you can go through this yourself and see some examples of the different types of tests. We saw with the hemochromatosis that testing of a single genetic variant, we know what we're looking for, and we're looking for a yes-no answer. In hypertrophic cardiomyopathy, it's a little more complex. This won't help. We could consider testing a single gene, which is more or less what we did with the cold-associated periodic syndrome. We knew which gene would be involved. But again, with HCM, it's complicated. There are a large number of genes that can be involved, some more common than others. So do we go with a gene panel, or are we looking in the dark so much we want to go into whole exome sequencing, sequence all the 20 or so thousand genes which may or may not be behind the disease? In this case, we have good diagnostic guidelines. There are strong guidelines of which genes should be tested. We will target a gene panel designed for hypertrophic cardiomyopathy. And one of the common resources in the world we use is developed by the NHS in England. It's called PanelApp. It's freely available on the internet. You search for PanelApp, you can find it. And this lists the genes that you should and could be testing to identify or diagnose a genetic condition. So this is the panel of genes that we tested. In general, in situations of like our patient, a 50-year-old male with a myocardial infarct, the diagnostic yield can be up to about 40%. If you have a family history, such as in our case, the diagnostic yield can be up to about 70%. Okay, but I'm happy with asking for a hemochromatosis test. I'm very happy asking for a lactose intolerance test. I'm not quite sure how to start doing a large gene panel for a complex disease like cardiomyopathy. I see the importance, but I'm not sure where to start. And so for this, we offer you a sort of walkthrough, a guideline of how you can do it. First, you need the clinical consultation, which could be done by yourself. It could be done by a genetic specialist. I know you have some genetic specialists in Mexico who can take care of this, who explain to the patient the utility of the test, take their consent for the genetic testing, and will explain the work through. Basically, we'll need to take a sample. Commonly, this is done with a blood sample, or some laboratories also like doing cheek swaps. I have always preferred a blood sample because it works 100% of the time. The sample is then sent to our laboratories for genetic testing, and in this case for next generation sequencing of our gene panel. The laboratory will report to you and to the genetic doctor, if you have worked with one, explaining the situation. And then we can put in place the support for the family, both the treatment, which you know how to do better than we do, and also the post-test genetic counseling. What does it mean for the patient's family? and we support you in this. So to finish, I just wanted to look quickly at what a genetic report should look like. To me, this is something very important. And you, as the doctor, as our client, you can insist that you get a genetic report you can understand. Let's take a look in a little more detail. A genetic report has to be accurate because it has to say accurately what we have found and what to do with it. It has to be eternal because the children or the grandchildren of the patient we have tested may need one day to use this information. And so it has to have a language that's understandable. It has to have references, what we did and what we didn't do. Thirdly, it has to be understandable. There is no use me sending you 1 million bases of DNA sequence as a report and expecting you as a clinician to be able to interpret this. That's the job of the geneticist. We have to give it to you in a form that you can understand, and it has to provide genetic information that is actionable, that will help your patient. So in a report, in a complex test like this, first we say, what do we know? You told us that there was a patient who had had a heart attack. He had a brother with HCM. Another brother had died. There was a family history. And you asked us for diagnostic NGS panel for familial hypertrophic cardiomyopathy. We explain in detailed genetic language what we did, the sensitivity of the test. We even give the list of genes we test, because imagine we had a negative result. 5 years from now, we may discover new genes that should also be tested. We need to know what was done. And then we give the genetic test results. First, we give it in genetic language, in eternal language, that the geneticist could understand 50 years from now. But we also translate it into something that is useful for you. We found a mutation in the MyBPC3 gene, and we tell you this patient is heterozygous for the known pathogenic mutation, blah, blah, blah. This mutation is one of the most common causes of familial hypertrophic cardiomyopathy in about 1% of patients. The identification of this mutation confirms the diagnosis. The treatment of the patient and other family members should be adapted appropriately. And I always like to give the most recent treatment guidelines when they are available. Again, we remind you about genetic counseling. We remind you about screening family members and how the disease can appear at any age. And so you should consider it even in young asymptomatic patients. If you get a result from your genetic lab you don't understand, please call them. Please say, this isn't good enough. I want a better report. I want it explaining. So back to our starting point. I hope you've seen that we can use genetic tests in many different situations, very common, like lactose intolerance, intermediate, like hypertrophic cardiomyopathy, very rare, but you still see rare diseases, like cold-associated periodic syndrome. And you can use these to diagnose. So what I hope is you've got a little bit of a feeling how to think genetics. And I go back to one of my distant ancestors in the United Kingdom, a British clergyman and philosophers who had the concept of Occam's razor, that the simplest explanation is usually the right one. If you have an unusual presentation, you have unexpected comorbidity, signs together you shouldn't have, a family history, probably there is only one cause. And so let's look for the single cause, which might be a slightly unexpected genetic disease. Thank you for your attention.